I think very appropriate that I'm the last speaker, since I guess most of the patients are going to end up in this time, even if with successful transplants and stuff. But these are my disclosures. I speak for 2 companies. However, their products have nothing to do with this talk. Tried to think of what to teach you about palliative care in a very short time. And so a couple of things. One, palliative care is not hospice. And that is something that a lot of people don't know. I walked into a room about 3 weeks ago up in Smilo, walked in, said I'm from palliative care, and the woman burst into tears. You know, here comes the Grim Reaper, that's it. A short bit about opioids, and then mostly about advanced care planning, best started at an early stage of the disease to help later on. Don't know. It troubles me that we're being led into battle by a person wearing a bow tie. I hope that you all don't mind. So, hospice. What is hospice? If you ask patients, it's scary. It's, oh my gosh, it's the place where you walk in the door, the person never comes out again, they pull the rug out and whoop, right down through. Actually, hospice is, and I'll go more about that in a minute, but hospice is a place to go where what you're doing is focusing on comfort. My record is I had a woman with bilateral lung cancer who I referred to hospice, and she lived at home with hospice for 4 years, 1 month, and I forget how many days at this point. Every time they looked at her, she still had bilateral lung cancer. It just wasn't going forward fast. So people can be in hospice for a long time and be comfortable. One of my patients did a tour of Europe for a week and a half while on hospice. So people need to think a little bit differently about it. There is home hospice. They can have hospice in the home, and there is inpatient hospice at places like Brantford. But this is the picture I want you to remember for palliative care. Okay, so, no, sorry. Don't know what to push here.
It's the little red.
Little red?
The laser? Yeah. Right. Sorry. It's right here.
Thank you. So, death, yes, and bereavement care. So hospice right here, this is when all you're doing is keeping someone comfortable, and that can be a very short time or a long time. But here, earlier on, this is a time of diagnosis where curative care or life-prolonging care goes on at the same time as palliative care. Oh, you can't hear me there, sorry. Apologies. So these 2 things go on at the same time. When someone gets diagnosed with hepatocellular carcinoma or really any life-limiting disease, there's a whole lot of choices for treatments usually. And at the same time, although this goes to 0, people do often have symptoms, which is what brings them to the doctor in the first place. So most palliative care is actually done by the hepatologist or the surgeon. If you do something that's not to treat the disease but to make the patient feel better, that really is palliative care. So you all do it too. As time goes on, if this person's going to get worse, there are fewer curative life-prolonging choices, and usually there are more symptoms and more severe symptoms. And so for this person who ends up running out of options, going to hospice, as I said, for however long, and then they end up dying. Or they graduate from hospice. There are some people who don't get worse, and they get sent home because their disease reversed. Don't know how that happens, but it does. So please try and remember that. Someone who's from palliative care, it's not hospice. Hospice is a small part of what we do. Okay. 8 domains of palliative care. And the only reason I show this is because we get called for all sorts of different things. For palliative care, our main treating group is a doc, a nurse, a social worker, and a chaplain. And we all meet together to discuss the patients every day. I had a patient a year and a half ago whose main problem was, why is God doing this to me? And the suffering that this person was going through was horrible. I've been a good Catholic all my life. I've been to church. I've given money. And why am I going through this horrible disease? And whereas I can talk a little bit about that, my chaplain was a heck of a lot better. So the suffering can be all sorts of different types of things, and using the different people on our team can be very helpful. So this is the definition of palliative care. Specialized medical care for people with serious illnesses. It can be cancer, it can be cirrhosis, it can be end-stage diabetes, definitely just serious illnesses. It's focused on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis is. Goal is to improve life, and this is important for both patient and the family. American medicine is great at focusing everything on the person in the bed. However, you will have a spouse, a friend, a child sitting in the chair next to them, and we often ignore that person. And in many ways, that person is suffering more than the person with the disease. If you look at the B movies, and they capture the guy with the secret formula, they don't torture him. They torture his child or his wife, because it's much worse watching someone suffer. Well, there's some types of suffering I wouldn't want at all, but watching someone else suffer is horrible. So we've patient and family, and we are an extra layer of support. We don't take the patient unless it's very end of life, but it's an extra layer, one who cares mostly about how they're feeling. It's at any stage in a serious illness, not just at the end, and can be provided, as you saw, at the same time as curative treatment. So hospice, the prognosis is less than 6 months. The reason, I don't know about all of you, no one gave me a crystal ball when I graduated from medical school, but the 6 months comes from 1982 when Congress passed the law saying that Medicare dollars could go to pay for hospice. And so they passed the Medicare health benefit, and they said, wait a minute, this looks really good, everyone will want it, so how are we going to limit it? So they came up with this idea of 6 months. So the 6 months is an economic idea, not a medical idea. And that's why it doesn't really make a whole lot of sense, but it is part of hospice. Palliative care, anytime during the illness. Hospice, the focus is on comfort only, whereas palliative care can be combined with curative or life-prolonging care. Hospice gets paid in a very specific way. It's capitated, a certain amount per day, whereas palliative care gets paid the same way as you guys do. How many of you treat patients? How many of you have consulted palliative care? Oh, good. Excellent. Thank you. Leave out the when. So when to consider palliative care. So if the patient has a life-limiting illness, these are times to think about consulting palliative care. So the surprise question, which is for palliative care, for hospice, it's would I be surprised if this person died of his or her disease within 6 months? Because you don't have to know it's going to be 6 months. But for palliative care, usually, would I be surprised if this person died of his or her disease within the next year? Would I be surprised? You don't have to be sure, but if you wouldn't be surprised their disease is serious enough, thinking about help from palliative care would make some sense. Hospital use, repeated trips back to the hospital, repeated admissions. Serious symptoms, sometimes functional or social factors, either troubles going on at home or IV drug use, things like that, where we can be helpful as an extra layer of support. When people get admitted for symptoms, often pain, shortness of breath, and for advanced, and I'm sorry, the D should not be there, advanced care planning. Okay, opioids. Actually, all the leading pain relievers act the same, though some may be quicker acting than others. Why use opioids? They relieve pain and shortness of breath. There's no analgesic ceiling. One of my patients with hepatocellular carcinoma, he right now is on MS-Contin, so long-acting morphine, 400 milligrams 3 times a day, and he takes 24 milligrams of oral Dilaudid when he has pain. And when he gets chemoembolization, we go up to 40 milligrams of Dilaudid at a time. He works on a horse farm and takes care of the horses. He is fully functional on that amount of opioid. And he couldn't, when I met him, he was curled up in bed all day. So opioids are important, and you can go up on them. Doesn't make the liver, the kidneys, the gastric mucosa any worse, the way Tylenol, ibuprofen can, and there's no increased risk of bleeding. And just very briefly, so opioids to know, what gets used more than likely is oxycodone or hydromorphone. The trouble with oxycodone, which I see used a lot on Klatskin, is that the active metabolite of oxycodone is oxymorphone, which is actually twice as strong. If your liver's not working so well, then you may get much less oxymorphone. The oxycodone won't be as effective. On the other hand, some people are genetic rapid metabolizers, and it can go to oxymorphone very quickly. So there can be a lot of difficulties in figuring out exactly how oxycodone is going to work. So I think that Dilaudid is probably, or probably should be, the short-acting opioid of choice in this population. I do use morphine earlier on, but as they get more cirrhotic, morphine can build up in the body and cause all sorts of problems like seizures. Methadone, which I use a lot for pain, I don't use much in liver patients just because it's so long-acting that if there's a problem, it takes a long time to clear. And the fentanyl patch, for someone with a lot of fluid in their body, it's not going to absorb very well. The oral fentanyl, I'm just leaving here for a second because these are the fentanyl lollipops or pills that go underneath the tongue. They're very expensive. But the good thing about them is fentanyl has no active metabolites, and oral fentanyl, they work very quickly as far as pills or non-IV go. They can kick in within about 15, 20 minutes, and then they would go away very quickly. So they're good. They would be very good for procedures or someone who has to get radiation or something like that. Okay, advanced care planning. That's how I feel some of the time, like the Grim Reaper. However, this is what a lot of people feel like when you actually start talking about it. However, what I'm going to say, I think we need to start talking to our patients about it earlier than we do. So palliative care, we're guided by goals of care. Lots of times well, you'll see in a minute, but lots of times what happens is you get a second-year resident or an intern in the emergency room going into a patient and saying, well, do you want to be resuscitated? Or do you want to be, intubated? And what the heck does a patient do with that? Ideally, what you should do, one thing, it should be done by the clinician who knows them well. But these are possible goals that patients are thinking about. When you first get diagnosed, often I want to be cured. I want to have the disease go away. Then, okay, it's not going to go away, but I don't want to die early. Or I want to maintain my function or get better. I want my life, I want to live as long as I can. As the disease gets worse, please relieve my suffering. Maybe just focusing on quality of life. Staying in control, I want to stay in my house or I want to continue driving. Can be support for families. What's going to happen to my family after I die? And at the very end, often the goal is a good death. Taking those into account can help with the discussions of what to do next. But unfortunately, this is what happens a lot. Mr. T is 52 years old, was diagnosed with hepatitis-related cirrhosis about 6 years ago. Despite warnings, he continues to drink a bottle of wine each day. Recently had increasing abdominal distension. In the past week, his wife noticed increasing forgetfulness and sleeping during the day. Today, she called an ambulance because he would not wake up and had a fever of 102. gets to the emergency room. The medical team asks Mrs. T questions about the severity of his illness and how aggressive he wants to be. She's never heard of advanced care planning and is now responsible for carrying out her husband's wishes when she is not really sure what they are. Is this fairly common? Unfortunately. The people who then have to, this wife has to now make decisions when it hasn't been talked about. And the amount of stress that people go through when they don't know can be really a problem. So how can we help these people? And it's just having the discussions earlier. So there is very little data in cirrhosis, but there's good data in cardiology, good data in pulmonology, that there are a lot of benefits to advanced care planning. Better quality of life, improved patient satisfaction with care, reduced hospitalizations, increased use of palliative care services, yay. It can be very, very helpful. Okay? And then at the bottom, improve surrogate decision makers' confidence and reduced anxiety and depression in family members. Remember that when you have someone with cirrhosis, with hepatocellular carcinoma, as they're nearing the end, the one thing that we can do for the family who's going to lose someone they care about, the one thing we can do for them is have them at the end feel that they did everything right. They didn't screw up. They did what the person who's dying would want them to do. Because often they're left, they don't know. And there are a lot of family members who end up blaming themselves for the death. So early use of discussions are important. Patients, as you know, they can get significant symptom burdens, which can make it difficult. Hepatic encephalopathy, it's hard to have a goals of care discussion there, and there can be unpredictable declines in health. So the questions, most are open-ended, and in fact, when I start having a conversation like this with a patient, I want to figure out what they're thinking about at that point, and I will usually start with something like, how are things going? How are you doing today? Because I want to find out what they're thinking of, because if they're thinking about why am I not getting TPN, and I want to talk about something different, they're not going to hear me until I get to the end, and then they can ask their question. So I want to figure out where they are, what they're thinking about. But this is to help them identify their own goals and encourage them to share those goals with loved ones. So just sample questions. What is most important to you in life? Or what aspect of health would need to be taken from you for you to feel that living was worse than dying? Or are you, this is more very specific, but this is how to give information. Are you a detailed-oriented learner? Or do you prefer a general plan? Or saying to the patient, very ill patients with cirrhosis cannot always make their own healthcare decisions. How would you feel about discussing how cirrhosis may affect you in the future? See if they're ready to have that discussion. If you were to get really sick, is there anyone you trust to make medical decisions for you? Does the person know what is important to you? And encouraging that conversation to happen. Prognosis, which can be very challenging, of course. To make sure that both you and your family are prepared, I'd like to address both the best and worst case scenarios regarding how your cirrhosis may progress. And sorry about the talked, but can we talk about these now? Again, and they may say, I'm not ready yet. Okay, but at some point, they will be. Some patients ask me how cirrhosis will affect how long they live. Are you interested in this type of information? And again, you're not going to say, oh, you're going to be dead in X amount of time, but you can help them if they're thinking it's going to be years and years and years and years, and you're thinking, oh my gosh, we're talking months and months and months. You can help start to move how they're thinking. Disease complications, investigations we've done show that your disease has worsened. I'd like to discuss how that affects what treatments and therapies are going to help you live best quality of life possible. And end-of-life wishes. What would be important in your last months of life? Or, the question I often end up asking, where would you prefer to die? Again, that's something that's happening close to the end, but it can be important. Maintaining hope while discussing prognosis. You want people to be able to hold both ideas. You know, they're waiting for a transplant, they're hoping for a transplant, but maybe asking them, have you thought about what would happen if you don't get a liver? since a lot of these people aren't going to get them. And hope, 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 rug gets pulled out. Trying to have these conversations and keeping hope, but helping them prepare in case they're one of the people who doesn't get a liver. Summary, palliative care can be integrated with life-prolonging care at any time. Opioids can be helpful and even necessary for the comfort of the patient with cirrhosis. And advanced care planning is a crucial part of care for any patient with a life-limiting illness. I found this a few days ago. It doesn't really go anywhere, but I wanted to put it up. And questions. Thank you very much.